Hi all. Thank you for joining today's live Aspen Health for All conversation. These conversations are part of a larger effort housed at aspenhealthforall.org that is amplifying the important work being done by leaders and innovators all over the world to address the disparities that have been amplified by COVID-19. Our aim is to focus on health equity and connect a range of experts working on the front lines of health around the world as we all pivot to respond to the challenges of COVID-19. We're in search of common solutions and shared insights. And as the US reckons with the legacy of racial injustice and the continued systematic oppression of Black lives, we want to take this moment to say that we will not tolerate violence and hatred against Black communities. Our global community stands tall with local leaders, collaborators, healers, and fellows who have long been beacons in this moment and whose voices and work are critical to reshaping a healthy, equitable future for all. Today, the Aspen Global Innovators Group is excited to host a conversation with Erasma Monticciolo, Executive Director of Power of Two, and psychiatrist and professor at UC Davis, Dr. Ruth Shim. We're honored that Dior Vargas will moderate today's session. Dior Vargas, a Latina feminist, mental health activist, and creator of the People of Color Mental Illness Photo Project. And as a reminder, please feel free to ask questions throughout the session using the Q&A box. With that, we would like to get started with Dior.
Hi, everyone. I'm really excited to be having this conversation with you all. So thank you so much for joining us. So I also wanted to thank Ruth and Erasma for sharing their expertise and participating in this conversation. So let's get to it. So what is the current state of mental health in the US, specifically urban communities of color? And then also what's happening globally. So I wanted to get started with Ruth so she can give us some background on what's been happening around the world.
So thank you, Dior, and it's great to be here. And just to kind of set the stage, what we're learning more and more and starting to understand is that oppression and injustice is bad for mental health. So communities around the world that are traditionally oppressed and marginalized and exploited and traumatized are more likely to have a greater severity of mental illness and substance use disorders. And because they are, the inequities are built on the system, and that racism has been a factor and design in the construction of our system and our mental health system in particular, then oppressed and marginalized communities are more likely to have difficulty accessing care. And so when we do access care, it's most likely in times of crisis or when there are other options have been exhausted. And also at times providers are not as diverse as they need to be, or they don't have the shared experiences with the people that they are providing care to. And sometimes they can even discriminate against people who are seeking help. So this mirrors problems that are taking place globally, but in fact, in other countries, there's just a lot of greater flexibility in designing models to try to overcome these challenges. And so we noticed that in global communities, they are more effective sometimes in increasing access by better utilizing community health workers and members of the community to be able to deliver care.
Thank you so much, Ruth, for sharing that. A lot of the things that you mentioned definitely applies to urban communities in New York City. So Erasma, I'd love to hear more information about the work that you do at the Power of Two.
Sure. Thank you so much for inviting me to be here. And Dr. Ruth Shim, thank you for sharing that global perspective. Although statistics alone don't really capture the devastating human cost of mental illness, they do provide us with a snapshot of the current state of mental health in New York City. In New York City, for example, 1 in 5 adults experience mental health disorder in any given year. And this includes anxiety, substance abuse, depression, psychosis, and trauma. Major depressive disorder is the single greatest source of disability in New York City, but yet less than 40% report receiving treatment for it. In underserved communities like Brownsville in Brooklyn and the South Bronx, where the majority of the population are people of color, the mental health is actually a whole lot worse. According to a 2018 New York City Community Health Profile, what we saw was that the average annual citywide rate for psychiatric hospitalizations was 600 compared to 1,900 psychiatric hospitalizations in Brownsville. That is triple the citywide rate. This is, attributed to difficulties in accessing preventive health services, mental health services specifically, and interruptions in health insurance coverage. And as an organization that focuses on in-home parent coaching, and we collect a lot of data, we have seen that 70% of the external referrals that we make have been for mental health services.
Thank you so much for sharing that information. Yeah, I think a lot of times people are assuming that the only reason why specifically Black, Indigenous, POC do not get mental health treatment is because of stigma, but it sounds like there are so many other things at play. Ruth, I'd love to hear more about what you think about this.
Yes, it's absolutely true. The majority of Black and Latinx people with mental health problems who are seeking care do not actually get that care. And there was this great study done by Syria Lang that found that Black people in particular with mental health problems cite cost as the main reason that they did not seek care. And they cited that as much higher than on a lack of awareness of their symptoms, or because they were minimizing their symptoms. And they cited it at a much higher rate than stigma as well. So the problem, again, is a structural one, because people have problems accessing insurance. They have problems with insurance reimbursement, service delivery. And yet in medicine, we sometimes tend to have this problem where we seat the pathology in the individual. So we say that it's the person's idea or the person's refusal to seek help, rather than problems with the structure of the system. And so we don't look at the systemic issues that are causing harm. And I can't remember who said it first, but we are beginning to understand this concept that the system works the way it was designed to work. And when we think about the mental health system, it was basically designed to exclude oppressed and marginalized communities and people of color, and it's working.
Absolutely, it's definitely a structural issue, and it's unfair to put the onus on the individual when there's so many other things that are at play. So in terms of the disparities, I think COVID has been an example for people when it comes to lack of care, specifically for BIPOC. Erasma, a lot of things have been happening in New York City. So could you share more about what has been going on in New York City?
Sure. In terms of, just to speak a little bit to what Ruth was saying, we have seen in our work that this whole idea of stigma is inaccurate. As Ruth mentioned, the biggest issue has been access. The plain truth is that mental health services are incredibly expensive. I mean, take it from someone who accesses mental health on a regular basis. It's incredibly daunting. The expense is daunting. A survey conducted by Community Care Brooklyn a couple of years ago found cost to be the biggest barrier in accessing mental health in my community of Brownsville, Brooklyn. Other barriers also include incredibly long wait lists for intake, just to get an assessment, or even after the assessment, then you have to wait months for treatment. Then there are other barriers that we must also consider, like the lack of access to transportation. That's very challenging for a lot of people in my community to travel long distances to access mental health services. Childcare is also an issue, right? They can't go to the therapy sessions with their children. And so the cost of childcare is also prohibitive. And some folks are just unable to take time off. And then for those individuals that actually are able to access the mental health services, practitioners, as Ruth mentioned, aren't always representative of the communities they are serving, and may not have the cultural competency necessary to really support people of color, which in many of the families that we interact with, we hear that all the time, that it's not that they don't want to access mental health, it's just that the person on the other side doesn't really understand all of the different challenges and all of the current stressors that they're experiencing that make it difficult for them to get to sessions.
So either one of you, beyond what you've already shared, how do you think that these misconceptions about stigma and lack of access harm BIPOC?
I just think generally what happens is there's kind of an internalized process that just kind of builds on itself. And so I often find when I talk to medical students of color, when I talk to them and say, oh, you should go into psychiatry, they say, oh, well, I don't want to go into psychiatry because, you know, we don't access mental health and we have stigma. And so there's this perpetual, and then if we talk about and we share, if I share this data, the data that Erasma presented, and we talk about this issue, often I notice that people, our students all of a sudden are like, wait, I never thought about it that way. And now I realize I can have an impact. I can go into this field and have an impact. And so I think that we tend to then, in our communities, internalize some of the issues that we're seeing occur, and then we believe that it's these causes that aren't really the causes, and they're not necessarily as internal causes as we believe them to be.
Yeah, and I'm thinking about how COVID has been complicating things and how we're all being forced to be isolated because of quarantine. And I'd love to hear more, Erasma, about how that is exacerbating the mental health challenges for BIPOC.
Yeah, you know, the demand for mental health services was already high pre-COVID, and COVID-19 has definitely compounded that need. People who previously coped well are now less able to cope because of all of the multiple stressors brought on by COVID, such as unemployment, remote learning, caring for an ailing relative, housing insecurity, limited food access, and the list goes on. And so those who were already struggling are also at increased risk, including children. I think they're very important to this conversation. Children who are now, because of all of the mixed messages that they're receiving regarding health or returning to school, et cetera, are at an increased rate or an increased risk for anxiety. The other thing is therapists themselves have been overwhelmed, right? They have their own situations at home that they're having to contend with, or they have been redeployed elsewhere. So the few that were stationed in certain communities are no longer there. And all of this really results in many people of color in my communities, to turn to self-medication, to smoking or alcohol, for example. And so I think that right now we have a really good opportunity with home visiting program like ours, but also with telehealth, because telehealth could be instrumental in addressing the current climate and could really facilitate expanded reach to people in need of mental health support in the future. However, I do believe that it's going to require investment and a detailed knowledge of the local landscape where services are being rolled out. I can tell you that, my organization, for example, transitioned our home visiting program to a virtual platform. But before doing that, we conducted a really thorough tech assessment to fully understand the extent of the technology disparity with our families and with the communities. And then we tried to remedy that by doing fundraising and providing loaner iPads and Wi-Fi connectivity to families to really help support their access to our programming, but also to other services, while also training all of our team on the technology pieces that are really critical to ensuring a successful interaction and really delivering our program while maintaining fidelity. So all of these different initiatives are really critical to really responding to the need of our people of color in vulnerable communities.
Thinking about all the work that you both have done, and it means a lot to a lot of people, but also to me. And what is really important for me is learning more about where you're coming from, what has influenced your work. The personal is political, so I'd love to hear more about how you both have gotten to this work. So I'd love to hear from Ruth.
Yeah, it's funny because I always wanted to be a psychiatrist. And so when I went to medical school, I did my medical school and my residency training in Atlanta, Georgia. And I worked in two very different hospitals. One was the richest suburb of Atlanta, and it was predominantly middle class and upper class white folks that were my patients. And then the other was one of the poorer sections of Atlanta. It was the patients there were predominantly Black and Indigenous people of color. And the inequities were so blatant. They just kind of smacked me in the face kind of day after day after day, because I was the same doctor working in each setting, and I was using the same treatments, and I was using all of the same skills. But there were differences in outcomes, and there were differences in how people did with the same conditions and the same illnesses. And as a Black woman, it was very difficult for me to believe how I had been taught to believe that the differences were a result of maybe some type of biological or cultural inferiority of Black people, which was just subtly and covertly implied throughout my education, and is subtly and covertly implied throughout all of medical education. So I had to take the time to kind of re-educate myself about what the actual cause of inequities were. And I discovered there's this whole wealth of information, often in fields of critical race theory and anthropology and sociology, that I just wasn't aware of because physicians tend to not be taught about that. So when I tried to address these things and take them to my own professional organizations, I was faced with a lot of resistance and pushback, a lot of people that believe those false things that they were taught. And so I made the decision recently to leave the American Psychiatric Association, because it made me realize that if I'm truly battling to address mental health equity, that there are other fronts and other battlefields to do this work in.
That's amazing. That definitely must have taken a lot of courage. So I think that you're really setting an example for staying true to who you are and what you won't let happen. So thank you. Erasma, I'd love to hear more about how you came into this work.
Sure. Thank you, Ruth, for sharing that. I grew up in Brownsville, Brooklyn, where my organization was founded. And I experienced trauma as a child. I was a child of immigrants, and I was what they call a reverse barrel child. I was born in the United States, but spent my formative years in the Dominican Republic, then returned at the age of 7. And it wasn't until my adulthood when the confluence of the trauma that was already embedded in my biology and the stress from a challenging birthing experience with my second child, that culminated in postpartum depression and severe depression, where I had episode of psychosis. And it was through that very difficult journey that I came face to face with the reality that the level of privilege that I had attained afforded me access to some of the best therapists to help me get healthy. Yet there are hundreds of thousands of women of color that do not have that access and could, through basically no fault of their own, repeat the cycle of trauma for themselves, their children, and their family. And so to me, my goal through my work, or our collective work, is to really promote healing for families, to promote parental confidence, to promote social emotional well-being in children, and really develop secure parent-child relationships, because all of those things combined have been proven to really help children thrive. But we have also found that can help decrease depressive symptoms in the caregivers that we partner with, as well as build community resilience. So this is very personal work that I'm doing.
Thank you so much for sharing everything that you've been through and showing your vulnerability. I think that that's so important. So I'm seeing that we're nearing the end of our moderated conversation, and I definitely want to, for everyone to be able to get their questions answered. But to start off, this first question, which has been throughout our whole conversation, how do we combat a system that restricts so many from receiving care and support? Ruth, sure, why don't you get started?
I think that there's a lot of strategies, and one of my colleagues, Sarah Vincent, says, you know, your advocacy ain't my advocacy. And I think there are many different ways to go about trying to get this, do this work. I find that any attempt and intention is a start in the right direction. So definitely education and self-reflection are kind of the most important foundational things. And so thinking about and learning about what these inequities exist, where these inequities come from, why they exist, why they persist, I think is step one. And then kind of reflecting on your own role in that. And then once we have that education in place, when we're armed with that knowledge, then every interaction becomes an opportunity, a possible opportunity to advocate or to advance equity in mental health.
Yeah. I mean, I think that definitely a bigger investment on the national level, understanding that there are limitations to health coverage. So making sure that we demand that Congress takes that on. And I think that on the more granular level, creatively thinking about what are the existing programs that exist right now that could make this possible, right? And so we're seeing, as part of our home visiting work, that we are sometimes the first point of contact for many families who haven't accessed mental health themselves, but through our reflective practice work are able to identify those particular triggers or trauma points that then make them more open to accessing mental health. And so really thinking about infusing home visiting programming with kind of like that mental health understanding so that we can relay or make those connections to mental health providers. But also, as Ruth mentioned, taking the time to invest in training, taking the time to make sure that we're identifying and supporting, you know, people of color in our communities who have a genuine interest in social work and in psychotherapy and psychology, and finding a way of supporting their learning, their education, and their ability to actually embed themselves in the communities where they're from so that they can themselves help communities heal.
Thank you for that. There have been a lot of questions about what people can do. One of them is, how can people from other professions bring these conversations into the workplace? Ruth, let's get started with you.
I think because we have this myth of stigma, it shuts people down and it prevents them from talking about it, talking about getting all of this on the table. So we rarely kind of share as bravely our personal experiences and stories the way Erasma did. And I think if we had more people who were brave enough to share their stories, what we would start to understand is that this affects all of us, that we all have mental health and substance use problems. And we also have this myth that people with mental health and substance use problems are just non-functional, or they're just kind of barely scraping by in the world. And the truth of the matter is most people have either recovered or are in the process of moving towards recovery. And recovery is definitely possible. So I do think that part of it, part of what people can do is start to be brave enough to share their stories and to bring these conversations into workplace settings and to start saying, okay, you know, this is my experience. What can we do in this setting to try to make it so that other people are able to recover, or that other people are able to have access to mental health services and substance use services? And what can our organization do you can start, think globally, but act locally. Each individual workplace is an opportunity to look at your policies, to look at what your benefits are, what you provide for people to be able to access mental health and substance use disorders, and to have a conversation about maybe you should be doing more, or maybe there's ways to do more in that space.
Yeah. I definitely agree with Ruth. As a home visiting organization, a lot of our team members experience vicarious trauma, right? So they have their own history with trauma, but then they're going into the home and they're seeing it play out over and over again. And so as an organization, we are really committed to self-care. We have open dialogue about what it is that's being experienced, and really incorporate reflective practice in all of our supervision and all of our meetings, to really make time and space to have those conversations. And I lead the charge. I talk about my anxiety. I talk about the fact that I go to therapy, still twice a week after, the last 7 years. And that's an important part of my healing, and part of my work, and part of the understanding of why we do the work that we do. So I think that organizations, again, really need to invest in creating space for those dialogues, create opportunities either in their budget for self-care stipends, so that folks have an opportunity to really access and take that time off that they need, and really think about how to connect team members or staff to providers in the community that are easily accessible to them.
Absolutely. I definitely agree with the importance of starting these conversations and sharing your story. Personally, for me, that's something that is what I'm doing very often in my work, sharing my experiences with trauma, domestic violence, living with PTSD. So it does give people a representation that I think a lot of people don't see. Very much what you were saying, Ruth, like people think that they aren't able to function. And really, it's quite the opposite. It shows the resilience that people have, that with a mental illness, they can be productive and really successful people in their lives. So I really appreciate you both saying that. So another thing I wanted to talk about is, well, when you were talking about organizations, I feel like a lot of what's been going on with the Black Lives Matter movement, and how organizations are now showing that they believe in intersectionality and Black Lives Matter. What are your thoughts about these organizations? Often I wonder if it's genuine, because I feel like when it comes to these issues, mental health is severely impacted by that. So I'd love to hear more about your thoughts about where these organizations are coming from. Ruth, let's get started with you.
So I think that it is nearly impossible, and my colleague Sarah Vincent and I have a book coming out in January 2021 called Social Injustice and Mental Health, and we're really trying to highlight that all of the ills of society, all of the injustices in society, there is no way not to you cannot tease them apart from what happens with mental health and what happens with substance use disorders. So across every system, if there is something wrong with that system, if that system doesn't function the way it was designed to function, like the educational system, the criminal justice system, the child welfare system, all of the systems that we have set up in our country to be able to help people, if the system is not designed to help people properly, then the result happens is kind of illness within that system. So mental illness and substance use disorders are the end result of a system that has not been designed to function properly. So these organizations that are working to push against and reform and improve the system, I think are very good vehicles by which people can start to bring about change. And so just one really quick example is how Black Lives Matter has kind of moved into thinking about defunding the police. And as soon as you talk about defunding the police, all of these issues around mental health come up, because then that exposes the point the very strange thing we do in this country, which is we criminalize mental illness. And oftentimes when someone is in a mental health crisis or when someone's having a substance use disorder crisis, we call the police to respond to those issues. When with other health problems, we don't typically call the police when people are having an emergency. So that if you're going to talk about defunding the police, then that funding has to go somewhere else. And there is a lot of discussion about how mental health is the place that much of that funding could be reallocated to in order to improve outcomes. So these organizations, I think, are critical in helping us move forward and make the kind of changes we need.
Thank you. Erasma, do you have any thoughts?
Yeah, I definitely agree with what Ruth is saying. I also believe that we need to focus on the wealth gap. The wealth gap is real, and it is very closely correlated to improved health outcomes. So I think one of the things that the organizations and the social justice movement is doing is bringing that to the forefront, bringing the conversation to the limelight, and really helping, I think, our government think about the importance of, you know, restorative justice, right? And right now there is a bill, I believe it's called HR 40, that is looking to establish a commission to examine slavery and discrimination in the United States from 1619 to the present. And through that commission, hopefully make recommendations that would be, you know, recommendations around remedies, right? And those remedies maybe would include reparations, and certainly reparations could lead to us closing that wealth gap and being able to really fully address the root cause of trauma in our communities.
Thank you both so much. So we're at the end of our conversation. So I just wanted to thank you both for sharing your knowledge and your expertise and also expressing your vulnerability. So thank you so much. And I'm really glad that we had this conversation.
Thank you, Dior. Thank you, Ruth.
Thank you, Dior, Erasma, and Ruth. We hope that you will all consider taking action today to support the important work of these leaders. Please go to aspenglobalinnovators.org to find their websites and learn more about Aspen Health for All in tomorrow's newsletter. And please be sure to stay in touch, sign up for future conversation, and use the hashtag Aspen Health for All on social media. Thank you.